Hello, I'm Peter Feniak. The doctor has told you that your child has been diagnosed with vesicoureteral reflux. As a parent myself, I know you'll have questions, so during this video, I'll explain what vesicoureteral reflux is, why reflux is a problem, and how reflux can be managed. Later on, we'll ask you to fill out a confidential survey indicating which treatment you'd prefer. The urinary tract is made up of 2 kidneys, 2 ureters, the bladder, and the urethra. The kidneys filter the blood to form urine. Urine is then transported by the ureters from the kidneys into the bladder where it's stored. When it's time to urinate, the bladder empties through the urethra. Normally, there are small flap valves where the ureters meet the bladder. These valves stop urine from flowing backwards from the bladder into the ureters. When these valves are defective, urine backs up from the bladder into one or both of the ureters, a condition known as reflux. Reflux severity is graded on a scale of 1 through 5. 1 is the mildest, while 5 is the most severe. Children with grade 5 reflux may never outgrow the problem, but younger children and those with mild reflux have the best chance of outgrowing it. Children under the age of 1 may outgrow it in just a few years. For others, it may take longer for the reflux to go away completely. Reflux is usually a congenital, inherited trait. That means people are born with the problem and it tends to run in families. If a child has reflux, the chances of any of his or her brothers or sisters having reflux as well is 1 in 3, or about 35%. If a parent had reflux as a child, the chances are even higher. Here's why reflux can be a problem. Vesicoureteral reflux itself does not cause kidney damage or urinary infection. Most children with reflux have perfectly normal kidneys. But when the bladder becomes infected, the bacteria causing the infection may be carried into a kidney, and this may lead to kidney infection. If the infection is treated quickly, kidney damage can be prevented. Nevertheless, some kidneys do become permanently scarred from urinary infection. Fortunately, with early detection and careful management, the risk of serious kidney problems in the future is low. Parents have a number of options when choosing a treatment for their child's reflux. One choice is long-term antibiotic therapy to prevent urinary infections. Another choice is open surgery to correct the reflux. And the third option is an endoscopic procedure to correct the reflux. I'll explain each option in detail, and then we'll review the most important points of each option. Now, you'll remember that it is urinary infection and not reflux itself that causes kidney damage. So it's important that children with reflux avoid any urinary infections.
Use your medicine.
To prevent these infections, many children are kept on a low dose of an antibiotic until the reflux goes away. The antibiotic does not cure the reflux, it prevents urinary infection. When children are given an antibiotic to prevent infection, about 2 out of 10 of them will outgrow their reflux each year. This means that some children may have to stay on antibiotics for up to 5 years. The antibiotics are given as a liquid or pill once every day, generally have no side effects, and are not harmful to children. Children treated this way have their urine checked by their pediatricians whenever they have a fever, and have periodic bladder x-rays to determine if the reflux is still present. Bladder x-rays, like the one your child just had, are called cystograms, or VCUGs. This test requires bladder catheterization. In other words, a tube or catheter is inserted into the child's urethra every time this test is done. Pictures are taken during the test to determine if reflux is still present. The use of daily antibiotics over many years has been proven to be a successful way of treating reflux. Kidney infections are rare. In an average of 7 patients out of 10 with mild reflux, the reflux is gone in 5 years without surgical treatment. Also, in some children who continue to have mild reflux but don't get infections, the antibiotic may be stopped when they're 6 or 7 years old. This may be done even if the reflux persists. Even with preventative antibiotic treatment, about 1 in 10 children still develops urinary tract infections because the infections develop a resistance to the antibiotic. Now, this requires changing to a different antibiotic or choosing one of the other treatments. The second option for treatment is open surgery. Surgical correction of reflux requires making an incision in the lower part of the abdomen with the child asleep under general anesthesia. The ureter, or both ureters if reflux is present on both sides, is detached from the bladder and then reattached to form the normal valve that prevents reflux. Most of the time this is done by opening the bladder, but sometimes it can be done without actually cutting into the inside of the bladder. If it's possible to stay outside the bladder, both the hospitalization and recovery times may be shortened. Either way, this operation corrects reflux in more than 9 out of 10 children, and no additional procedure is necessary. Children who have this open surgery to correct their reflux stay in the hospital from 1 to 3 days and may require a catheter in their bladders for part of that time. They continue to take a daily antibiotic for about 6 weeks after surgery. Generally, only a sonogram is done to check the results of the surgery, but sometimes another bladder X-ray is done to check for reflux. The third way of treating reflux is called endoscopic injection. This procedure also requires a general anesthetic, but it does not require an incision. Instead, a telescope-like instrument called a cystoscope is placed through the child's urethra into the bladder. A natural implant material called deflux is injected through a long needle just under the opening of the ureter, as you can see right here. This causes an elevation of the part of the ureter that enters the bladder and forms a flap that prevents the reflux. The implant material injected is a sugar molecule that remains in place and becomes surrounded by a capsule of tissue formed by the bladder. This material is approved by the Food and Drug Administration, the FDA, and has been tested and used in the United States and Europe for several years. The material is completely safe, it has no known side effects, and does not cause any allergic reactions. Children who have endoscopic treatment for their reflux go home the same day and go back to school the next day. This procedure is relatively painless and takes about 15 minutes. Your child would then continue to take a daily antibiotic until a follow-up bladder X-ray is taken 2 or 3 months later. This would again require a catheter being placed in the bladder to check the results of the procedure. Depending on how severe the reflux is, about 8 out of 10 children are cured with this one procedure. And if it doesn't work the first time, most children are cured with a second procedure. If the injection of deflux fails to cure the reflux, it does not interfere with the success of open surgery. Please consider these 3 choices of treatment before you discuss this in further detail with your child's doctor. At the end of this video, we'll ask you to fill out a short confidential survey indicating your preference between the various forms of treatment, but be assured that your doctor will not see this survey, and how you answer will not influence his or her recommendation for treatment. Now once again, here are the 3 treatment options. Based on this information, consider which one you'd prefer. First, long-term daily antibiotics with the chance that the reflux will go away on its own. There are few dangers in keeping children on daily antibiotics other than a small risk of allergy to the medication and a small possibility that the child will develop antibiotic-resistant bacteria. Urine cultures will be necessary when your child has a fever, and these can be done by your pediatrician. X-rays with a catheter placed in the bladder are required every year to 18 months. Occasionally, children will have infections while on treatment and may need to have the antibiotic changed or to have the problem surgically corrected. The second option is open surgery. This is done with an incision in the abdomen with your child under general anesthesia and requires a hospital stay of from 1 to 3 days. This is a common operation with success in more than 9 out of 10 cases. After determining that the operation is a success, in most children the antibiotic used to prevent urinary infections will be stopped about 6 weeks later and a sonogram used to check the results. The third option is the endoscopic treatment using deflux. This is an outpatient method of treating reflux that does not require an incision. Although it's also done under general anesthesia, your child will go home the same day and be back to normal activities the next day. The procedure is relatively painless to the child and is successful about 8 times out of 10. Following the procedure, these children take an antibiotic for a few months and then get another bladder X-ray using a catheter after 2 or 3 months to check the results. If this procedure fails, it can be repeated or open surgery can be done. The most important thing for you to recognize is that with any of these choices, the chances that your child will develop serious kidney damage is very, very small. Just be sure that when you and your doctor decide on one of these treatments, that you follow through with the recommendations. Thank you for being a part of this survey. Let me reassure you that there are no correct or incorrect answers to the questions, and how you respond will not influence your child's treatment. When you've completed the survey, your child's doctor will discuss the problem with you in detail and answer any questions you have.